Thanks very much, Ben. Thank you to you and John for inviting me. And I'm not 100% sure that I've answered the exam questions set, but I have done one of the things you asked me to talk about, which is cost, the issues of non-price competition in the NHS. Anyway, let me share my screen. Oh dear, despite my best attempts, I hope you can now see my screen. Okay, so I'm going to talk, the title is Competition and Choice in the NHS, but I'm going to try and give you a kind of brief overview of some facts about the NHS, which I think, given the super knowledgeable panel and an audience you have, probably everyone knows. But I'm going to start with a picture that is very close to what Ben produced, which is some stats on the NHS. This is health expenditure per cap in the OECD. The red line is the average, and actually the UK is just to the left of the average. So it's pretty much an OECD average. What that means, interestingly, is in the pack of Northern European countries that it might be thought of as comparable to, it's actually below Northern European countries, and it's very similar to New Zealand, but it's also below other NHS type systems of Sweden and Norway, and indeed slightly less than Ireland as well. In terms of the kind of stats, I think most of you know this, but healthcare is free at the point of demand. It's entirely tax financed. That tax finance is national taxation. The total budget is about 130 billion for the last complete fiscal year, and it's about 10% of GDP. What this means is that activity and the budgets are given annually. So activity is totally driven by this kind of global budget. In terms of kind of some stats, the first decade of the 2000s, health spending in England actually increased at about just under 7% per annum in real terms. It was a big growth period. The decade after that has been a big decade of conservative governments all the way through and their austerity drive, which meant that the growth of healthcare spending was much less in the current 10 years. And this kind of goes on to activity growth, which was about 5% in the first decade, but fell to about half of that in the second. In terms of kind of how that money was spent, despite, I guess, kind of global views that we should be shifting away from hospital care and into community care and more into preventative care, actually what you've seen in the UK is a major shift towards hospital care in the past 2 decades. So family doc consultations only increased by under 1%, planned elective hospital care by nearly 10%. The other thing that's kind of worth noticing as a big picture is there's a large increase in the use of private care, mainly hospital services, purchased by the NHS. So they're using the private sector to deliver care much more. There's quite a big annual growth, albeit from a fairly low base. So that's kind of the statistical picture. In terms of broad NHS organisation, again, I think everybody in this conference probably knows this, but there are kind of 2 sides to the market. On the provider side of the market, secondary and tertiary services are mainly provided by public hospitals, but there's been increasing, as I say, private provision for mainly elective services paid for by NHS contracts. Primary care is provided by both a mixture of community care and by family doctors. And family doctors are kind of an interesting group in that they're actually technically not employed by the NHS. They have contracts with the NHS, but they only have one group. They only sell to the NHS. So they're a kind of funny body in the UK. In terms of what patients can do, They have some choice of hospital and some choice of GP. And that's been driven to increase considerably since 2000, when prior to 2000, they really had very little choice. On the payer side, we have, you know, a group that you might call purchaser or insurers, but they're basically local administrative based, geographical area based purchasing, and patients have no choice of purchasing. So the money comes down to those area based on a needs based formula. So it's very much a classic NHS system. So in terms of what Ben and John asked me to talk about, they asked me to talk about some experiments in non-price competition in this setting. So I think it's worth starting by a bit of history, which there were two large experiments in promoting supply-side competition. One, in fact, back in the 90s, which actually created this separation of the purchasers, the insurers, and hospital providers. Previously, the money had just gone to a local area and it had spent it on local services. So there was a separation and an introduction of selective contracting, interestingly, on price and volume. So there was price competition in that period of the early to late 90s. In 1993, the government changed to a Labour government, Tony Blair, at which point competition was viewed as something unpleasant and it was abolished. However, by 2006, Blair was pretty worried about the amount they were spending on the NHS and the pretty low productivity measures. Now, productivity measures are kind of crude, but it was pretty much flatlining. So in 2006, there was another round of pro-competitive policies. The key elements of this were enshrined in law: freedom for patients to choose hospitals, a shift from selective contracting, which had run in the abolition of competition period, to administered prospective payments, basically a DRG type system, which were to account for about 65% of hospital activity. Payment at that stage was not in any way related to quality, so it's basically payment for activity. The other reforms that kind of accompanied this were greater autonomy for hospitals that performed well. Basically, performance was judged in terms of getting waiting lists down, which are a key way of rationing care in the NHS, and performing well financially. Those hospitals were allowed to retain some of their surpluses and roll them over between years, and they were also allowed greater freedom over investment decisions. Investment is really financed by the private sector. And at the same time, there was greater use of the private sector to expand publicly funded provision. It's a bit unclear whether the policy was intended to give additional competition to NHS providers or just expand provision. It's kind of not quite clear what the aim of that was. So kind of in terms of what actually happened, I think as economists we can ask sort of three things. First of all, did the reforms change behaviour and market structure? If they didn't, then nothing happened. If it did change behaviour and market structure, the next question is, did this have any effect on outcomes or on processes or on productivity or indeed on equity, which is a major driver of the discourse around the NHS and the behaviour? And then which reform components were important? I'm probably not going to have time to talk about that. So in terms of behaviour and market structure, once this second set of policies was put in place, the kind of work that I and others have done showed that pre-reform, patient choice was severely constrained. Patients basically went to the local hospital. There were definitely signs that patients exercised greater choice post-reform. And in doing that, post-reform patients responded to quality and distance. So a lot of the fears over this was that patients couldn't tell any aspect of quality and would simply choose on the basis of distance and how easy it was to park your car. That doesn't seem to be borne out by any of the literature. We also found a bigger response in some services for sicker patients and no differences by income in terms of the response to quality. There was a significant reduction in market concentration. It was a pretty concentrated market, but it became less so. And we also found significant impacts on hospital market shares, such that better hospitals, in terms of lower death rates, attracted more patients post-reform. So that bit seems to be kind of working in the way that you might want it to be working. So having got to that, what are the kind of effects of these reforms? Well, this is payment by activity. And you saw exactly what you would expect to see, which is you saw increased volumes of hospital care. And in part, the reform was designed exactly to do that, to increase the volumes of hospital care. You also saw a larger role for the private sector, but this didn't reduce NHS provision. So essentially what you've done is you've probably moved down, at least in some elective services, you've moved down the severity curve in terms of what patients you're treating, i.e. you're expanding the amount of treatment and you're making the criteria for that treatment that patients are in less medical need, if you thought rationing beforehand was more or less in terms of medical need. In terms of quality, this has been perhaps the most studies. I think that the literature suggests either a mixture of positive effects, quality rose, or no effects. There are certainly no evidence of negative effects, but there's possibly some evidence that some of these gains might have started before the reforms. If you care about productivity, there's a lot less evidence. We do know that length of stay fell in less concentrated markets post-reform, and there's no evidence of greater spending. So the stats are on the right side of the line, but not clear how far they are away from that line. In terms of access and inequality, which was one of the kind of major worries, there's little evidence of differential effects by socioeconomic status as measured at small area level. The waiting times gap between richer and poorer small areas fell over the period of the policy, but again, this might have started in part before the policy. So that suggests that, you know, this non-price competition had beneficial effects. Nobody's ever actually studied a full kind of welfare reform, but you can also look at the kind of flip side of this, which is what evidence is there from earlier UK hospital consolidation? In the period between the first and second reforms, actually the government drove a huge wave of hospital reconfigurations. So over half the acute hospitals in the NHS were involved in a reconfiguration. The median number of hospitals in a market fell from about 7 to 5. What impact did that have on hospital production? We looked at a number of things and we found lower growth in admissions and in staff numbers, but no increase in productivity, i.e. the lower growth in admissions was pretty much matched by the lower growth in staff numbers. These reforms were primarily argued to drive a reduction in deficits. In fact, we found no reduction in deficits. Hospitals which merged probably had growing deficits, even 4 years after the merger, and no improvements in quality. So this mirrors actually quite a lot of the findings, say, from the US. So in terms of mergers, I think they were costly to bring about with very few visible gains other than a reduction in capacity. If you want to remove capacity, it's obviously one way to do it, but it's not necessarily the most cost-effective way of doing it. So in summary, kind of what do we know from the UK experiment in using non-price competition? The impact of the reforms, I think, appears to be positive. Patients and hospitals appear to have responded in a way that we hope they would. The patients choose, they trade off distance against quality. There's no price here. Hospitals that produced higher quality got more demand. Better hospitals attracted more patients. So quality rose without an increase in overall expenditure. In terms of where this was coming from, I'm not going to really have time to kind of delve into what was driving this, but some work that Nick Bloom and I and others, John Van Reenen and Stefan Seiler did, was suggested that some of this might be due to increased managerial effort, that competition causally increases managerial effort in the hospital market. From the other side, that the consolidation policy that ran in the first years of the Blair administration appears to have had the opposite effect, in that there seems to be very few gains from all of that, except to take out capacity out of hospitals, where you're sort of, by definition, taking out capacity by merging these hospitals and often kind of reducing duplication of facilities. Obviously, medics love this kind of policy, because they argue not only does, volume increase quality pretty much across the board, but I think they're kind of keener to have larger, bigger hospitals. So what I wanted to talk about a little bit was, in my last kind of 5 minutes or 4 minutes, was where now? Because we've had a major policy shift that's been kind of rumbling since about 2013. But has gathered pace. So what's happening now is a major shift from competition to integrated care, enshrined in the 2019 NHS plan. Now, integrated care has a lot of advantages, and we can see them in many places. And in some ways, it is kind of crazy in the NHS to have GPs doing one thing and hospitals at arm's length from them. So the aim of this is integrated care systems everywhere by 2021. These integrated care systems are defined at area level, and this is a quote from the NHS plan, which is they are supposed to bring together local organisations in a pragmatic and practical way. I'm not quite sure what the difference between those two things is, but anyway, to deliver the triple integration of primary and specialist care, physical and mental health services, and health with social care. That's a very big agenda, and those services are currently delivered by different groups through contracting arrangements. The idea is not that they form necessarily new organizations, but they will do this through the retention of contracting arrangements with greater emphasis on quality in those contracts, not just volume, and on purchasing bundles of care. Now, I think that's a great aim. The problem is that I think in an NHS system, there's always a drive towards consolidation. And certainly one likely outcome here is greater provider consolidation. It's clear that these are meant to take out spare capacity. I mean, there's not much spare capacity. NHS hospitals run at 90% occupancy rate, if not higher, which has been a real problem for COVID. We have to lock down a lot of our economy because we don't have any spare capacity. So there is already moves towards greater provider consolidation. I think that's been pushed forward further by the COVID epidemic and the way people have responded. And I think there's a question, will there be more integrated services, or simply will there be greater exercise of monopoly power by secondary care providers? I already showed you how secondary care rose a lot in the first decade of this century, even though the aim was to expand community care. And I also think there's a real problem with this model that it's area-based. How much patient choice will there be within these integrated care systems? So I think with those kind of questions, my own view is this is not a model without its problems, particularly in an NHS system that very much emphasizes spatial equity, equal treatment for all, and the same service, perhaps a bad one, to be delivered everywhere. So on that point, I will thank you and stop sharing my screen.
Fantastic. Thank you so much, Carol. That's super interesting. And we already have some questions lined up for after Sung Mai's talk. So with that, we'll move to Sung Mai to talk about Taiwan.
Sung Mai has left the call.
It does look like she has dropped.
Well, we'll give her a minute, and if she's not back in a minute, we can ask the questions to Carol and hope to get her back online. Well, why don't we dig into some of the questions with Carol since we're waiting for Sung Mai to rejoin. There's a number of questions. The first one from John Kolstad is, do we know much about the degree to which rationing is based on acuity?
Yeah, I get that. I mean, it's a very interesting question. I think broadly the answer is yes, but so that the system is that a GP refers to a hospital. GPs and purchasers don't have unlimited budgets. So GPs are part of a purchaser organization and they refer to a hospital. So they're not going to refer people who are kind of, the walking well. In terms of, the exact precision of when you got treated, so you get referred and then you're on a waiting list. Those waiting lists have fallen a lot from central efforts to reduce waiting lists and to set targets. I didn't talk about that at all, but this was a very target-driven set of metrics that the government uses, as well as publishing a lot of data on performance. So I think, there may be this thing that some of the consultants might take interesting cases before very sick cases, but in fact, I think broadly the answer to that is yes, because of the way the system works. And that was probably driven more post the reforms, but it's kind of difficult to show with some of the data. You'd probably need to look at something detailed like cancer registry data. So it's probably known for various specialties, but not kind of at a broad level.
Yeah, and I actually have a follow-up question, and this is going to be a broader question, kind of in the spirit of the people who study the U.S. health system and our general ignorance about other systems, which is, in the U.S. there's also a lot of discussion, obviously, about equity in care. But a lot of that is really focused on access in terms of payment, obviously. And so you touched in a couple of places on kind of capacity constraints and lines, but from a broad perspective, how visible and how important are kind of those issues in the UK system? Do you feel like kind of the queues for different kinds of procedures, and this could be as a function of acuity or not, are kind of especially salient, for example, in kind of the public policy debate?
I mean, they have been, Ben. Historically, waiting lists were long. I think in like 1990, you could wait, or even 2000, in 2000, before these reforms, you could wait 18 months for a hip replacement. But they've been very strongly driven down by this increase in volume of activity and the spending of money in the first decade of the 2010s. So waiting lists, and there are targets for particular things. Now, there are targets for waiting times in emergency room. There are also targets for how long you have to wait for something, particularly cancer. There's been big issues on cancer. And I think waiting times now are reasonably short. There's much less discussion of waiting times. They will rise, though, with COVID. And that's going to be a big issue for us going forward, that we've got this whole backlog of elective care sitting there because we had to move all our resources into COVID care, especially when you're running at 90%. There's no spare capacity that you can borrow from somewhere else. In Ireland, they bought a shed load from the private sector. We bought some elective capacity from the private sector. That was a kind of government mandate, but we didn't have much else, you know, for the COVID patients. We actually built hospitals to deal with them.
That's especially interesting, you know, especially in light of, you know, how you respond to something like COVID, which of course a year ago was not really something that was centrally on the mind of at least the kind of health policy that we do. I won't say policymakers overall. So I see Sung Mai is back. What I want to do is there's one more question for Carol. And so I want to finish the questions for Carol now, and then we'll do Sung Mai's talk and then the questions for her talk. So the last question I have for Carol is from Gautam Gaurasankaran. And he asks, do you have information on physician salaries and availability, which I presume he means capacity, kind of like I was asking, relative to the US? Do they have lower salaries and or higher availability? And obviously you just spoke to the latter part, but at least on the salary part, maybe you have more on that.
I mean, we do have data on salaries. I've got a data set that has the data for every single doctor in the NHS, and they are lower than the US. Partly because there are only two employers, one being the NHS, and it definitely exercises monopoly power, the other being the private sector. But you can only start private work once you reach kind of the level of being a certain level in hospitals. Now, obviously, one of the options is to go abroad, but restrictions on mobility of docs tends to be kind of higher than restrictions on mobility of other professionals. I mean, getting into the US as a UK doc, you really basically have to retrain.
Yeah.
So yes, they are lower.
Yeah, that's very interesting. I mean, I have about 10 follow-up questions, but we're going to move on because we want to keep on schedule. So thank you so much, Carol. It looks like Sung Mai is here and ready. So take it away, Sung Mai. Go ahead.
Thank you. Now I need to bring my slides up. So how do I do that?
At the bottom of your screen, you'll see a green button that says Share Screen.
Yeah, I thought I was doing that.
Just click that, and you should get a dialog box that allows you to choose.
I think she may be a guest. That might be part of it.
No, anyone can share.
Right. So do you see my slide now?
There we go.
There it is.
Please just go to full screen.
Okay.
There we go. Perfect.
Lovely, lovely. Yeah. I hope that our dilapidated infrastructure doesn't play tricks on me as I give my talk. And I apologize for making you nervous, Ben. Anyway, I'm going to talk about Taiwan's single-payer health system. And I have organized it in 4 segments. I talk a little bit about how it came about, because relative to UK's NHS, Taiwan's system is a fairly new one. It was established in 1995, so it's 25 years. And then we're going to look at briefly how it works, and then we go on to see how has it done, has it served what the government wanted it to serve in terms of objectives, policy, goals. And then we're going to look at some insights and lessons for American health reform, which we need very badly. Okay, first we have a very quick look at Taiwan. It's an island economy of roughly 24 million people. Last minute I decided to plug in some US data, and they're in red. The US, of course, at 328 million. And Taiwan is a very rapidly aging society. Although it is still younger than the US, which is younger than most European nations, but Taiwan has the world's fastest rate of aging. Now, Taiwan is a very rich economy. Look at the per capita GDP in purchasing power parity dollars. It's less than the US 63,000, but it is at par with Germany's, been higher than France, higher than Denmark, and South Korea and Japan, etc. Infant mortality, Taiwan is 4, which is a little bit higher than the OECD average, but considerably better than the US. But this is one area where I think Taiwan can do better. And then in terms of life expectancy, you can see that both men and women in Taiwan live longer, for women quite a bit longer than American counterparts. Now, how did it come about, the national health insurance? Before it was implemented in 1995, Taiwan had 13 social insurance schemes, but it only covered roughly 60% of the population. The uninsured rate at that time was 41% of the population. However, they're the vulnerable people, children, women, unemployed, and the elderly. But then on March 1st, the government implemented, in a big bang move, the government implemented the NHI, and overnight everybody in Taiwan became eligible to be covered in this program. And by the end of that year, by December, in 9 months, they enrolled 92% of the citizens. And then, of course, today, and it's been actually quite many years now, it's full insurance. Full universal health coverage. Now, I want to mention that, I think a distributive ethic in any health system is very important, because that ethic drives that system. In Taiwan's case, Taiwan's constitution has this provision. It says that the government is to provide social welfare. It shall implement social insurance institutions. Now, this one clause, article, provided the constitutional mandate for social welfare programs, of which universal national health insurance is one. And so in about the middle of 1986, the government decided to establish a universal national health insurance scheme to be implemented in the year 2000. And at that time, we look back in history, we see that there was a confluence of several conditions that were conducive to a bold initiative like this. And those conditions created what in health policy we call the window of opportunity for Taiwan. And these conditions are, well, Taiwan, it was one of the 4 Asian tigers or dragons. It had sustained economic growth. And so it became very prosperous. And it made financing of such a large social program possible. And also then when people get richer, they want more and better healthcare. And then there was also political competition. because by then a rapidly rising opposition party wanted to say kick the long ruling Nationalist Party out of office and take over. And so the ruling party, the Nationalist Party, said, well, let's compete. Okay, we're going to do this program. And then the government at that time also had leadership. It seized this opportunity, those three conditions I mentioned. And also this President Lee, he decided, well, you know, the earlier government say that let's do it by 2000, but let's move it up. Let's do it by 1995. And that's what he did. They actually shortened the implementation time. So, and I would like to also mention the role of scholarship, science, and evidence, because as we know that the United States is having a very bad case of this COVID pandemic, and there's much discussion about, you know, science, respect for science and evidence, and respect the experts. At that time, though, a health economist, for instance, Uwe Reinhardt, he was a listened to voice, and he was serving as a high-level government advisor at that time when they were planning. And he was what we should say the Dr. Anthony Fauci of health policy at that time, that his voice was listened to. And so the government respected and trusted him and listened to his recommendation to go to a single payer system. And that is how Taiwan today has its single payer system. So it's this one man whose idea was accepted. So planning, it took 7.5 years. I mean, nothing much happened in the earlier part of this planning period, but everything happened in the last year or two. And legislation, again, quick, 18 months, not like in the US Congress where it takes, you know, repeated proposals and defeat and then new proposals, etc. Implementation took 7.5 months, fast. And Taiwan rejected the US system. Reinhardt very specifically advised the government not to build their system based on the US system, because he said that the US healthcare financing system is so complex that it is almost beyond human comprehension. So, all right, let us look quickly how it works. First, the government's role. Now, the NHI is a government-run social insurance program, and it has a mandate. All citizens and legal residents must enroll, and it has guaranteed issue. The system takes everyone, regardless of pre-existing conditions or gender or age or socioeconomic status. And the government policy is, let's make this program affordable. So the premiums is very low. It's only 4.69 currently of wage and salary plus a supplemental salary of very small, low rate. And it gives subsidies as exemptions and ceilings for copays. So in Taiwan, actually, sometimes people ask the question, is the NHI too nice? I think that was one thing that was heard in the UK some time ago, is the NHS, or is nice too nice? But government set prices through negotiations. But of course, government as a single payer, it has monopolistic power. So it uses it to set prices. And then it uses national uniform fee schedules, not like in the US. You have thousands of different fee schedules between insurers and providers. There's no balance billing allowed, and there are no surprise medical bills. So these are what the government, the role government played. Now, in terms of financing and risk pooling, it is a premium-based financing based on per capita, but the per capita is capped at maximum of 3 persons per household. If you have more than 3 people in your household, the others go for free. You don't need to pay premium. And the premium is shared by 3 parties, the insured, the employer, and government. And as I said, there's subsidy for the poor and for, there are different kinds of subsidies for different population groups. There's no time to go into that. And then people are very good about paying their premiums. 98% pay on time. And in terms of risk pooling, it is a single risk pool. That is another sharp contrast to the US, where we have so many risk pools covering Americans by age and health status, like Medicare is for the elderly, for people 65 or older, and for the disabled, and the Children's Health Insurance Program for children, and also by socioeconomic status. You know, if you have a good paying job, you're likely to have private health insurance and you get good coverage. But Medicaid we have for the poor, and then CHIP again. And then if you're a veteran, then you go into veteran VA care. But such a fragmented system is hugely expensive to run. We spend billions and billions, and there's billions and billions of waste on administrative costs in the US system. Now the benefits, delivery and contracting quickly. Benefits are comprehensive. They cover pretty much everything. But the delivery system, don't think that a single payer system run by the government means that the government also delivers care. No, in Taiwan, the bulk of services are delivered by private providers. And then the overwhelming majority, 93% of providers, hospitals and clinics, and 100% of hospitals, they contract with the government to deliver services. Now, what about consumer choice and service use and access? Is there a waiting time problem? So there's, in fact, full consumer choice. There are no gatekeeper, and people can go doctor and hospital shop. You know, if you have the time, you can go see 5 doctors in the same day or visit 3 hospitals. No one is there to stop you. And so utilization in Taiwan is very high. You can see that the visits to doctors per person per year in Taiwan is 3 times that of the US and roughly twice that of OECD nations. This is in 2018. And the hospital length of stay also is much longer. And access is very easy because it's a highly urbanized society. So you can access doctors and hospitals within 30 minutes for over 80% of patients, usually. And waiting time for elective procedures, there's none seen as in other single payer systems in the West. Cataract surgery, for example, takes 11 days, you know, schedule, and then you're done. I want to mention the NHI's IT system because that system is a thing of beauty. The government decided to invest early in a system-wide IT infrastructure and gave it a common nomenclature for high efficiency. And you'll see how that system drives the system. The administration of the NHI is very simple and extremely low cost. It costs less than 1%. It's 0.77% of the total NHI budget to run that system in 2019. And that whole administration has a staff of 2,800 that serves close to 24 million people. So you can see that it's efficient. And it also, you know, they pay providers very quickly. In 2 weeks, you know, of your billing, you're paid. A word on this access. How do people access? You access it with a credit card size NHI card. And this card does a lot of things. It has your personal information and has your most recent visits, 6 visits, and has your diagnosis, has prescription information, allergy information, and organ donation instructions, and do not resuscitate instructions. And so this card is very useful, many, many uses. First of all, of course, it simplifies NHI administration, and it's very convenient for patients. But the magic of it is that with this card, because every time the patient goes to a doctor or hospital, it logs into the NHI system, and the government can see within 24 hours that this patient was at this provider. So if for a high user, for example, somebody who sees a doctor 100 times in a month, the government knows it. So it can do utilization and patient profiling. And by the same token, because the providers has to tell the government within 24 hours all the services it delivered within that 24-hour period, the government can know what services each provider delivered in that period. So you can do provider profiling if you want to. And the doctor, because of this utilization and delivery data, it knows exactly how much it is spending on a near real-time basis. And this last point is really a thing of beauty. It really helped Taiwan so much in the COVID pandemic because it facilitates COVID testing, quarantine, and contact tracing, etc. So there are other, I'll just mention 3 other important innovations. The Pharma Cloud in the NHI, it greatly reduces duplicate prescriptions. You can look, this is when in 3 years, 2014 to 2017. 2014 is when it started, and you can see how duplication of prescription came down, and that means savings in money. And then everybody have a personal electronic health record. It's called My Health Bank. It gives you 3 years of your personal medical data. It gives you, this allows you to manage your own health and health care through these health and risk management plans it gives you. And it also gives you hyperlinks to trustworthy sites for medical information. We all know that there are a lot of sites on the internet, but they offer unreliable information. But here the government helps you to go to the right information. And this is a really powerful system. It's called the MediCloud system. It's a personalized medical cloud system on an individual basis that all of these things about that person is entered into the MediCloud. For example, your prescription data, the surgeries you've had, all your records, lab tests, and images, CTs, MRIs, ultrasounds, etc., your dental records and results, and all these other things. It is all stored in the MediCloud. So when you go to a doctor, if you give the doctor consent, the doctor can then download all of this and see about you. So in a very short period of time, a doctor would have a very comprehensive of you, the patient, as a patient, as a whole being, and not just say, oh, my knee hurts, and he looks at just your knee. So in terms of performance, how has it done? We can see that in terms of health spending as a percent of GDP, Taiwan is at 6.1% of GDP in 2019. US, this is the latest OECD data, 17%, okay? And the OECD average is 8.8%. And in terms of per capita health spending, US is over $10,000, and Taiwan is a little over 3,000. And OECD average per capita is around 4,000.
Sung Mai, sorry to interrupt, but there's about 2 or 3 minutes left.
Oh, okay. You can also see that the growth is also very, very steady and low compared to all these other countries. So I'll just very quickly go over the insights. So we'll have a new president in 2 weeks. Regardless who is the next president, Taiwan offers lessons. The first one is that distributive ethics matter. Again, here Uwe Reinhardt says that Health reformers in Europe, Canada, and Taiwan, they begin their health debate. They debate on health reform by making explicit the ethical principle that should constrain health policy. In Germany, for example, that principle is solidarity. But America is different in that it has never been able to reach a politically dominant consensus on a distributive ethic for American healthcare. So in America, for example, you have progressives that think that healthcare is a pure social good, should be given based on the ability, not on the ability to pay, it should be based on healthcare needs. And the conservatives think that healthcare is a private consumption good, and it's your responsibility. And in between, there's a confused in-betweens, okay? And cost containment, Taiwan also offers very important lessons. And here I like to mention that prices do matter because prices determine spending and affordability. The high prices in US healthcare makes price unaffordable to millions of Americans. But in single payer systems, government sets prices. And prices are therefore far, far lower, and therefore spending is also far lower. Here's an example of prices. The US, look at the red dots that lined up in a straight line, the US dots. To the left of the line of red dots are prices in these different countries for different drugs and procedures. You can see how much lower prices in all these other health systems are. Here's one drug in the US, Xarelto blood thinner. The red bar is US, all the other countries are much, much lower. And another tool to contain costs that Taiwan used is global budgets. It's been shown to be useful in the OECD countries in the 1980s, and Taiwan's government implemented a series of global budgets, and that then contained health spending. We can see in this graph that before global budget, growth rate was over 8%, but after global budgeting, it hovers around 4%. And another insight is, if we want to reform the US healthcare market, which by gosh, we need it. We have 30 million uninsured, many more million uninsured. Americans can't afford to pay for COVID care. But then we need to pay attention to what is needed in order to do health insurance market reform so that we can cover people. Reinhardt, he has showed a diagram by way of a three-legged stool. He said, well, here's a three-legged stool in order to reform the insurance market, right? What do you need? You need guaranteed issue, which is, if Obamacare is overthrown, then that is uncertain. You also need a mandate, which America did away with last year. And then you also need subsidies, enough subsidies toward the purchase of health insurance. And you need all three of these together. If you miss one of these, then the stool will not stand. You will not cover everybody. Now, a quick word on competition and markets. You think that single payer, because it's a government run so that there's no competition, that is not the case with Taiwan. In Taiwan, competition is alive and well. But there, because prices are set by government, the government fee schedule is the basis to pay all providers. So providers there compete on quality of services. Because there in Taiwan, the money follows the patient because patients can go anywhere he or she wants. So, and then there are no surprise medical bills and no price discrimination in Taiwan because extra billing is not allowed in Taiwan. And government fees pays everybody provided the same, and so you don't have the rampant price discrimination, which is very vastly different prices paid for the same services depending on who you've contracted with in terms of the payer, the insurer. And there in Taiwan, hospital mergers do not lead to increases on price. They merely increase the market share of acquiring hospitals. And of course, being so efficient a system to run, there was huge administrative savings, less than 1% of the total budget, compared to 3% for the OECD average, and strikingly different than the US. In the US, with 7% for Medicare and 13% for administrative costs for private health plans. And then what about satisfaction? Single payer systems in America, you often hear that it's government monopoly, it's government takeover, it's socialized medicine, but so you can't have it. But single payer systems around the world, most of them are highly popular. Taiwan, UK, Canada, Denmark, the American Medicare, the VA, etc. So see, in socialized medicine, government runs both insurance and delivery, but in Taiwan, the government only does the insurance part, and the patients have free choice of doctors and hospitals in a predominantly private system. And so people are happy. They're really, really happy. And it shows that choice of insurers is not important. Choice of providers is what is important. So here's my last slide. There's some et ceteras for US health reform. I'll just, this is a question, empirical question for us Americans. I talked about window of opportunity that helped Taiwan bring about major health reform. The question for us is, will COVID pandemic present a window of opportunity for US reform? And then, of course, COVID also, it highlights the importance of leadership. You just look at the COVID-19 responses, US versus Taiwan, and we know why it's important. In Taiwan, to date, they have roughly about 535 COVID cases and 7 deaths in a population of roughly 24 million. And then wouldn't it be nice if in the United States, we can have something like the NHI card, PharmaCloud, my health bank, MediCloud, etc. And I stop here. Thank you.
Okay, thank you. That was really, really very illuminating and fascinating, and gives me some hope for the world after being just inundated with U.S. health discussion for so long. So thank you so much. That was especially fascinating. So given the time, there's a bunch of questions. Given the time, I think I'll ask one question that is kind of I guess a compilation of several different questions that were asked, but kind of synthesizing them together. Then after this session, we'll take a shorter break. So there's a question from Claudio Lucarelli, which is, how heterogeneous are preferences in terms of technology use? And if so, how are they accommodated? The related question, which I wanted to kind of tag on top of that, is a question from Samantha Byrne, which is there any role for private health insurance in Taiwan? So these questions connect because, one of them is asking, well, if there's heterogeneous preferences, first of all, can consumers get actually kind of follow those preferences? And I guess then the question would be, well, if not, do they have to get some kind of private insurance?
All right. Well, first of all, I think it pays to keep in mind that the benefits covered by Taiwan's national health insurance extremely comprehensive, and so if you just lived on what those covered benefits are, you do very, very well indeed. Now they do in recent years have made exceptions for a few basically medical devices where they do offer people a choice, such as intraocular lens when you have a cataract surgery, or when you have a joint replacement, when you have a cardiac stent. They now allow you to say, on top of the standard NHI covered device, they allow patients choice, free choice, but they also make prices available for patients. See, that is a valuable, precious part of the Taiwan system. Here, we try to bring about price transparency, but it doesn't work, or has not worked, I should say. So there is choice for some of these things. And so far it has worked well. Okay, people are highly satisfied, because you can see that satisfaction is 90% in Taiwan for their healthcare system. Now you can say, well, what about private health insurance? Private health insurance is something that many other healthcare systems in the world use in order to supplement the public insurance. Where what the public insurance doesn't pay for, the private health. Like in Canada, the Canadian federal Medicare doesn't pay for drug benefits, doesn't pay for dental. So private health insurance take that up, employers do that for their employees. But in Taiwan, all these things are covered. You see, it's really covered: inpatient, outpatient, dental, prescriptions, drugs, traditional Chinese medicine. Everything is covered. And so there's no private health insurance in Taiwan that plays a substitutive or supplemental role. You will hear in recent years that, oh, private health insurance is growing rapidly in Taiwan. But though they are, the so-called, I'll put parentheses around private health insurance in Taiwan. They are really, I call them, for the sake of time, they're savings tools. They are cash indemnity payments. See, and usually they're taken out as riders on bigger policies like life policy. See, if I have a life policy, I'll take out a rider, say cancer. So should I be diagnosed with cancer, then I get a lump sum payment. You see? And with that, I can do anything I want with it. I can use it for a private room, hire a private nurse, etc. So private health insurance, I would say, doesn't exist the way it exists and works the way it does in other healthcare systems.
Yeah, well, as someone interested in insurance markets generally, that last product you talked about, which is more like kind of lump sum payment insurance against getting a major disease. That's just very interesting in and of itself. Okay, so unfortunately we should move on. I have a feeling for most of the sessions today, I'm going to have a similar feeling where I want to keep talking, but I have to stop. So right now it's 10:17. The next session was supposed to start at 10:20. In the interest of giving everyone at least some break, let's restart at 10:25. So let's take 8 minutes, and then we'll go into Gautam,